Lung cancer is the most commonly diagnosed cancer and the leading cause of cancer death worldwide, and about 85% of cases are linked to smoking. Although screening programs exist for high-risk populations, barriers such as high costs to medical systems, staff shortage, and radiation concerns limit the deployment. The participation of eligible patients in the US remains as low as 20%. The formal recommendation is that high-risk population undergo low-dose CT screening every 12 months. The LungRADS is a structured reporting system that guides the management of nodules found on low-dose CT screening studies. There are 5 LungRADS categories that can further be categorized to 2 pathways: routine pathway with annual low-dose CT follow-up. 84% of patients belong to this group, and the actionable pathway requiring additional workup or closer follow-up. Digital tomosynthesis reconstructs radiographs into layered images, reducing overlapping structures. It serves as the gold standard for mammography, and its broader imaging applications for whole body are growing. Recent digital multi-tube technology, scanning at multiple angles, has lowered the cost of such machines, and compared to chest CT, chest DTS offers lower cost, low radiation dose, and shorter reading times for the radiologist. In this study, we aim to evaluate whether a supine chest DTS may have a role in lung cancer screening. Our rationale was that if DTS can reliably identify patients who can remain in the routine pathway, it could potentially reduce the overall CT burden. 35 patients that underwent full-dose CT for various clinical indications and agreed to participate in the study and undergo DTS within 1 week interval from the CT were included. All patients signed informed consent. The CTs were performed on various machines, and all DTS were performed on a Nano-X ARC machine. 3 radiologists reviewed the CTs and the DTS independently in an arbitrary order blinded to the patient's identifiers, and the majority score was used. The radiologist noted the presence and size of lung nodules. If the patient underwent a biopsy from a lesion between the 2 studies, the lesion was excluded from the evaluation. The patients were classified according to the LungRADS and then categorized to the routine versus actionable pathway. Results: the group concordance was 100%, and none of the patients shifted to another pathway. Inter-observer agreement was similar between CT and DTS. There was almost complete concordance between DTS and CT categories for each radiologist. And here are some examples. This is a part of a DTS study focused on the relevant area. As I mentioned earlier, we should focus on the sharp structures only. And now we're moving from anterior to posterior. There's a large lesion in the right apex, but this lesion was excluded because it was biopsied. And there's a small lesion here. This was the lesion that was measured. And you can see that the lesion measures less than 6 millimeters on both modalities. And this patient belongs to the routine pathway. This is another example, a far anterior image with calcified rib cartilage. And as we move backwards, there's one lesion and a second lesion. Both lesions measure more than 6 millimeters, and they're in the actionable pathway. The patient is in the actionable pathway. And on tomosynthesis, the patient remains in the actionable pathway. There are limitations to this study. First of all, the patients had known abnormalities and did not meet the screening criteria for lung cancer screening. The sample size was small. The study is based on nodule size only, and the DTS measurements were performed on coronal plane, and on CT, they had both coronal and axial planes. And on the other hand, CTs were full dose and not low dose CT, and the radiologist had no experience in reading digital tomosynthesis. This was their first study. We started validating our results on a true lung cancer screening population and a larger sample size. And in conclusion, our study shows that DTS may have an impactful role in lung cancer screening programs by significantly reducing the number of CTs and, as a result, reducing the economical burden, the radiation dose, and professional workforce burden. Thank you.